Moving forward, I would like to welcome our next speaker, Dr. Ankur Shah, who is a consultant musculoskeletal radiologist at Sadbhav Imaging Center and Gujarat Imaging Center. He obtained training in musculoskeletal radiology at USA and Austria. He is also one of the joint editors of Indian Journal of Radiology and Imaging. I would like to once again invite Dr. Ankur Shah on the dais.
Thank you, Dr. Isha, for the introduction, and a very good morning to all of you. It is a pleasure to have you all on a Sunday morning, and to all our viewers who are all across the world. Good morning, good afternoon, wherever you are, if you are in the eastern part. Starting with this topic of the knee joint pain, I would like to show a few imaging tips for the knee joint. We know that knee joint is an extremely important joint because it has all our weight, and that is why any abnormality or any subtle pain in the knee joint is extremely disturbing. There can be various causes of knee joint pain. There can be traumatic causes, but we are more focusing right now on the non-traumatic causes of the knee joint pain. What are the imaging modalities that can help us in detecting the problem? It can be starting from the plain radiograph, which is always a basic tool, very much helpful in detecting certain abnormalities. But now with the more advancing imaging modalities, we have ultrasound, we have MRI, as well as sometimes CT scan that can also help. So plain radiograph is, as I said, always a basic tool. It gives us details about the joint space, about if there is any calcification or osseous abnormalities. Like here, there is reduction in the joint space in the medial compartment. We know that this is the classical picture of osteoarthritis. In severe cases, there could be even valgus deformities, which are very nicely visualized with just a plain radiograph. So it gives us a lot of information, though it is not enough. There are many things which are not seen with the radiograph, particularly the soft tissue structures. And that is where ultrasonography helps, particularly when the structures are superficial or when we are looking for the joint itself. So to see for the joint fluid, when there is synovitis or synovial effusion, ultrasound is a good tool. It is a good tool to evaluate the soft tissue structures which are superficial, like muscles or some of the ligaments. Like here we can see the fatty atrophy of the calf muscles. You can evaluate it very easily with the ultrasound. It is cheaper modality, easy to access. We can even do follow-up, we can do bilateral comparison. So these are the advantages of ultrasonography. Like here, there is a tendons which are around the knee joint. They can be very nicely or easily evaluated with the help of ultrasound. We can see the fluid in the bursa adjacent to the pes anserine tendons, and this is the appearance of pes anserine bursitis, which can lead to pain at the posteromedial aspect of knee joint and which can be really annoying for the patients. But there are some limitations of the ultrasound. It does not evaluate the deeper structures, particularly the anterior posterior cruciate ligaments, which are very critical in evaluation of the knee joint. It cannot evaluate the meniscus completely. Maybe we can see just the outer part of the meniscus, but rest of the meniscus is not visualized with the ultrasound. And it has limited utility for evaluation of the cartilage and subchondral bone, which is again a very important aspect of the knee joint, because so many of the pain in knee joint, they comes from this part. So all these modalities might show us various findings. If particularly we are scanning a knee joint of a patient who is 60 or 65 years age, we are going to see some degeneration in the meniscus. We are going to see some changes in the ligament. But what we are concerned is, what are the pain generators? What is the reason that has led to the pain in that patient? So many of these findings might be non-specific and which may not have any clinical significance. So we need to understand whether it is ligaments like cruciate or collaterals, whether they are the muscles and tendons which are causing the pain. It can be meniscus, though meniscus has the neural part is only the neural innervation is only in the outer part of the meniscus. The inner part of meniscus is it does not have blood supply or the nerve supply. Or it can be cartilage and subchondral bone. Again, cartilage is devoid of blood supply, but when the cartilage loss is more, then it can lead to subchondral bony changes, and which can be extremely painful. Or sometimes it could be vascular structures or some neurovascular structures which are around the knee joint. So we need to identify which is the pain generator. Like here, if we see the MRI of the knee joint, you can see there is diffusely enlarged anterior cruciate ligament, which is showing like a celery stalk kind of appearance. We can see the fluid locules between the ligament fibers, and even there can be a cyst formation. And we know that this is the classical appearance of the mucoid degeneration of the anterior cruciate ligament, and this can be severely painful. Patient is not able to flex the knee. The pain is more while standing. So all these are classical symptoms of the mucoid degeneration of the knee joint. Sometimes it can be tendon, like here. We already have a talk on the jumper's knee, and this was a volleyball player. As you can imagine, there is a lot of jumping involved, and he had edematous changes involving the patellar tendon at its attachment with the patella, and this is the appearance of the patellar tendinosis or jumper's knee. So we know that this is the reason of pain for this patient. Meniscus tears, it can be of various types. There are different ways of grading those meniscal tear. I'm not going in all details, but it can be a vertical tear like here, longitudinal. It can be a horizontal tear, or sometimes it can be a displaced flap tear where the flap fragment, it acts as a loose body. So all these meniscal tears, they may not be painful, but particularly when the tear occurs in the outer part, which resultant the parameniscal cyst formation, because this is where the neural innervation is there. So this will lead to stretching, and it can result in pain to the patient. More importantly, what happens is once the meniscus is torn, it leads to significant increase in the degenerative changes in the knee joint. So as you can see here, there is a tear in the meniscus. Associated with that, there are areas of cartilage thinning and cartilage degeneration in the femoral condyle, as well as on the tibial part, and resultant subchondral bone marrow edema-like signal intensities. These subchondral bone marrow changes, these are the main reason of pain for the patient. When the tear occurs at the posterior root, like here, there is a posterior root tear of medial meniscus. The meniscus gets extruded, that comes out of the knee joint, and again there is increase in the osteoarthritic changes in the knee joint, which can lead to pain. So whenever there is no meniscus or meniscus is torn, like here, whether it is a medial meniscus or it is a lateral meniscus, there is significant rapid progression of the osteoarthritic changes compared to the side where the meniscus is present. So we can easily see here it is the medial compartment where the meniscus is completely torn, and you can see the full thickness loss of the articular cartilage with subchondral bone marrow changes, and same changes are also seen on the lateral compartment in another patient. So usually the medial compartment is most commonly affected by osteoarthritis, but when the meniscus tear is on the lateral side, then even the lateral compartment osteoarthritis can also be more severe compared to the medial compartment. Cartilage injury is a complex thing. There are a lot of stages and grades of the cartilage injuries, like here. It can be grade 1, which are very superficial lesions, or grade 2 lesions, which are little more deeper, or grade 3. All these 3 grades, they are limited to the cartilage. But when it is grade 4, that is full thickness cartilage loss with subchondral bone changes, this is the condition when the pain becomes more severe because of the involvement of subchondral bone. So we need to look at the details of the articular cartilage and its grading so that we can evaluate what is the reason for patient's pain. If it is full thickness loss with subchondral bone changes, like here, there is complete loss of the articular cartilage in the weight bearing part of medial femoral condyle, in some part of the lateral femoral condyle, medial tibial condyle, and there is complete loss of cartilage in the patella also, with significant subchondral bone marrow changes. And these edema-like signal intensities, these are the cause of patient's pain. And once the changes are severe, we need to address that. We need to do some intervention or do something to help the patient. So to take home, there are various imaging modalities which help in the evaluation of painful knee joint. MRI is extremely useful modality which allows visualization of soft tissue as well as bony structures, and it is important to find out the pain generator and address that for the better management of the patient. Thank you so much.
Thank you, Dr. Ankur, and I would like to call Dr. Shraddha Makwana along with Kunjal to felicitate him.